There you go.
Thank you. So, hi everyone. Good morning. I'm Wendy Lau. I'm talking about blood products for cardiac patients. So, first of all, I understand that this may be an international audience. So, what I talk about are the blood products that we use in Canada. So, in your own country, if you're not in Canada, it might be different. Your blood products, the basics are the same, but the way they make blood products in the blood center might be different in different countries. So, I'm only going to talk about how we make blood products in Canada. So first of all, we start by talking about transfusible products, and these are we call components. Components are made directly from a blood donor. So, and it's produced by the Buffy coat method in Canada. So a unit of blood is collected as whole blood, and then it goes to the blood center, and it will be centrifuged. And the top part is the platelet pool plasma, the bottom part is red cells, and the middle part is the Buffy coat layer, which is the white cell layer. So this is a schema of the type of blood bags. So when a donor donates blood, it's donated as whole blood. So on the left side, that kind of bag is called a B1 bag, and it has a platelet bag. So the BC is the Buffy coat. So from there, 4 Buffy coats are put together to make a unit of platelets. On the right-hand side, this is a different kind of bag. This is called the B2 bag. And here, the bags go into making red cells, plasma, and cryoprecipitate. So depending on the need of the system, the blood center decides to put out one or the other kind of blood bags into the donor clinics, and so they can collect the various types of components. And this is what it looks like. This is the centrifuge. That centrifuges the whole blood unit. So the top is the plasma, bottom red cell, and the middle part's the Buffy coat. And then they sterilely dock 4 Buffy coats together, and then they hang them. So the 4 Buffy coats are sterilely docked together, and then they add a unit of plasma from one of the 4 donors of these units. And so 1 unit of Buffy coat platelets consists of platelets from 4 individual blood donors. During this process, white cells are removed, and it's called leukoreduction. Because white cells really do not provide any benefit in the transfusion. White cells predispose to febrile reactions and platelet refractoriness. They harbor organisms like CMV and HTLV, which lives in white cells. And there's a theoretical risk of abnormal prion transmission and a theoretical risk of immunosuppression. And so white cells are removed in this production process. And in Canada, we've been doing this since 98 for platelets and 99 for red cells. And this is called pre-storage leukoreduction, meaning the white cells are removed at the blood center before they are stored either there or in the blood bank. So when we transfuse blood, we still need a filter at the bedside. And this is not a leukoreduction filter that we use at the bedside. It's just a regular blood-giving filter that removes clots that might form during storage. So even though the blood center has already leukoreduced by filtering the products, we still need to use a blood-giving set to filter out the clots that might form during storage. So what do they do? What does the blood center do after they collect the blood? They do a number of tests on the donor samples. So that includes ABO, RH, blood type, a red cell antibody screen, and a number of infectious disease screen, because we're always concerned about transmission of bloodborne viruses from the donor to the recipient. So the number of infectious disease that they do, it's quite extensive. So that includes HIV 1/2 antibody, HIV nucleic acid test. This is a test to look for the virus itself. Hepatitis B surface antigen, anti-HB core, and a nucleic acid test to look for HBV DNA. Hepatitis C virus antibody and a nucleic acid test by PCR. A test for syphilis. A test for HTLV1/2 antibody. This is a virus that is bloodborne. It's uncommon in Canada, but it's common in some parts of the world. I shouldn't say common, more common in some parts of the world, like the Caribbean and Japan. West Nile virus is transmitted from mosquitoes to human, and so they test them during the season where we have mosquitoes. So they monitor the season, and when they find there is West Nile virus in mosquitoes, that's when they start testing. So roughly from May to November in the Northern Hemisphere. This test is by nucleic acid test. Chagas, they test only on certain donors. Chagas is a parasite that's common in Central and South America, so they only test those donors who've lived there or emigrated from there. CMV, cytomegalovirus, they test on some donations, not very many, which I'll go into in a bit. They do bacterial testing on all platelet products. So after all these tests, the risk of viral transmission is very low. All these viruses, the risk of transmission is very low, but there is still a risk of transmitting bacteria. The bacteria can be either from the blood donor or from during the production. And the rate of bacteria in the products is higher in platelets because platelets are stored at room temperature and red cells are stored in the fridge. So it depends. The rate of bacterial sepsis depends. With bacteria testing of platelets, it is in the lower range, as I put down here, rather than the higher range. Okay, other infectious disease risks. There is malaria, and there are 1 or 2 cases per year in the USA. There have been 3 cases reported in Canada, none in recent years. There is no good test to test blood donors or no good rapid test that can test blood donors for malaria, so they rely on the history. If a donor has ever had malaria, they are never allowed to give again. And if the donor has traveled to a malaria risk country, such as they went on vacation, they cannot donate for 6 months. Next. Babesiosis is another red cell parasite, and this babesia, it's common in northeastern parts of the United States. So people get it from camping in the woods in Massachusetts and Connecticut. There are quite a number of cases of transmission in the USA. We only know of 1 case in Canada. Variant Creutzfeldt-Jakob disease is the disease that is associated with the mad cow disease, or BSE, in England and Western Europe. And there have been 4 cases of probable transmission. There is no good test to test blood donors for VCJD, so they rely on history. Anyone who's lived in the UK or France for 3 months, or Western Europe for 5 years, are not allowed to donate in Canada. So CMV is a bloodborne virus. So CMV can be transmitted by transfusion. Is this true or false?
True, ma'am.
True. Right. And CMV is a cell-associated virus because everything is leukoreduced. All blood products are leukoreduced. So leukoreduced blood products are comparable to CMV negative products in preventing transfusion-transmitted CMV infection. Is that true or false? And it's true. So sick kids, we no longer order anti-CMV negative blood. When we say CMV negative blood, we really mean anti-CMV negative blood. That means CMV antibody negative. Most people who have antibodies to CMV no longer are infectious. Once you've had the infection, you would have CMV antibodies for life. So it doesn't mean they will still transmit infection. So depending on the country, the prevalence of positive CMV antibody can be low or high. In Toronto or in Central Ontario, it's about 60%. So 60% of blood donors have CMV antibody because they've been previously exposed, but most of them are not infectious. So if we still go by CMV antibody, then we're going to exclude a lot of donors who are not infectious. Plus, CMV is removed by leukoreduction. According to the National Advisory Committee recommendations, this is a Canadian National Blood Committee. They recommend that CMV negative blood be only given to intrauterine transfusions. And we don't do intrauterine transfusions at sick kids. And so that's why we no longer keep an inventory of CMV negative blood. So let's go on to the different type of blood products. Red cell concentrate, it's to use for tissue oxygen delivery. The volume is about 300 mils. Produced by the Buffy coat method, they add a additive to it, saline adenine glucose mannitol, or what we call SACAM. And so a typical unit contains very little plasma, and mostly the supernatant is additive. This additive is a nutrient for the red cells and allow the red cells to be stored for 42 days. So SACAM red cells have a shelf life of 42 days. When we transfuse to kids, we generally transfuse by mils per kilo rather than by unit. Like adult patients, you would say give 1 unit or 2 units. In children, we calculate by mils, especially for small children. So 10 mils per kilo will increase the hemoglobin by about 10 to 20 grams. For small children, if you're giving a lot of red cells, we remove the additive. We call them plasma reduction, but really it's removing the additive because too much adenine can be renotoxic. So if we're giving a lot of red cells to a small child, we remove the additive before transfusion. And that happens in the operating room fairly often because many of the cardiac surgery that we perform at sick kids are on very small children. But once we enter the unit, to remove the plasma, the unit outdates in 24 hours. If we use a sterile docking device, it has a longer shelf life, but it's a few days versus the 42 days. So that's why we only do this right before we issue blood to the operating room. The maximum time at room temperature for a unit of red cells is 4 hours because we are concerned about bacteria in the unit that can multiply when it's left out at room temperature. Okay, so for patients over 4 months of age, these are the general guidelines for transfusion of red cells. So active blood loss, low hemoglobin with symptoms of anemia, and if they are on ECMO. So on ECMO, they keep them at a higher hemoglobin. Patients under 4 months of age, it's a little bit more complicated. Babies are born with a higher hemoglobin, so and the age and the hemoglobin varies with age. So they're born with a higher hemoglobin, and then they drop to another about 3 months, and they start to come back up again. So to transfuse babies, we really have to look at how old they are, whether they're ventilated, whether they have symptoms of anemia. So that's why the schema is slightly more complex than older children. So what does the blood bank do for cardiac surgery? So when they do pump surgery or bypass surgery, they use red cells and plasma to prime the circuit if the child is under 10 kilograms. If the child is over 12, they prime with albumin. So between 10 and 12, it depends on the child's status as well as previous surgery and other things. But generally, we do not need to prime the circuit with red cells if they're over 10 kilograms in body weight. So on the day of the surgery, we prepare 3 units of red cells. 2 units are relatively fresh, and it's listed below. So the younger the child is, the more the blood is in proportion to their blood volume. So that's why we give them fresher unit if they are small. If they're bigger, then in proportion, the unit is less of their blood volume. So we can give them older unit. In a small child, we also give a unit of FP and everybody we give albumin for priming the pump. So and TCO and FlowSeal if they request it. For patients under 1 year, we always put a unit of platelets on hold in case they need it. And they usually give platelets at the end of the bypass when they come off bypass. And this is due to dilutional effect as well as can be some platelet dysfunction while they're on pump. So the platelets are not issued at the beginning of the OR, and we hold them in the blood bank. And when they request it, then we give them a unit. Usually they are small kids who need platelets because they have small blood volume for the dilution. So they only ask for a small volume. So we would remove, make an aliquot of the unit. So let's say if they want 50 mils of platelets, we would just give them 50 mils of platelets. And the preparation of red cells, I've already talked about why we need to plasma reduce. So if the child is under 10 kilograms, because they have a small blood volume, we plasma reduce all the red cells to remove the additives. If they're over 10 kilograms, we only plasma reduce if we expect them to need a lot of blood products. And this is the scheme for post-op. So what I just talked about was what we do for patients in the operating room. So post-op, this is our CCU protocol, and they have an algorithm as to for help them to decide when to transfuse or not. So they look at whether they post-op, whether they have a single ventricle, whether and the oxygen saturation, and whether they're cyanotic or acyanotic. So if they have a cyanotic heart disease, they need a higher hemoglobin for the oxygen delivery. And if they are not cyanotic, then they can go for a lower hemoglobin. So I'm going to talk about selecting compatible red cells here. So are you all familiar with what the blood groups and which blood type you can give to which patient? So briefly, you can give group O to anybody. So that's why group O is a universal blood donor. AB, you can only give to AB because they have A and B antigens on their red cells. But plasma is the opposite. Plasma, because group O people have anti-A and anti-B in their plasma. Oops, sorry. The problem with moving the cursor. And so if we can only give group O plasma to somebody who's group O. whereas group AB plasma we can give to anybody. So the compatibility for red cells and plasma is just opposite. So platelets. So platelets made by the Buffy-Coat method is made from 4 donations. And I mentioned that they add 1 unit of plasma from one of the donors to the pool. And that 1 unit of plasma is from a male donor. We generally try to avoid using plasma from female donors, whether it is in platelets or using plasma, and that is to minimize the risk of TRALI. TRALI is transfusion-related acute lung injury due to donor white cell antibodies, and females who've had babies can have white cell antibodies because they can be stimulated by their pregnancy. So we generally just use male plasma. So a unit of Buffy-Coat platelets contain about 300 times 10 to the power 9 platelet in about 340 mils of plasma. There is another method of making platelets, and this is called single donor apheresis platelets. These platelets are collected by apheresis procedure. The donor is hooked up to an apheresis machine, and they collect the platelets and return the red cells. And so one donor can donate roughly the same amount of platelets as 4 units of Buffy-Coat, and that's why they call it single donor platelets. So we use the 2 interchangeably depending on the inventory. So an adult dose for platelets is 1 pool or 1 apheresis platelet. The pediatric dose is 5 to 10 mils per kilogram, up to maximum 300, because that's the adult dose. So for small children, relatively speaking, they'll be getting more by getting 10 mils per kilo. But if the patient is a big kid, like 50 kilograms, they're still getting an adult dose. They're not getting 500 mils. So when we aliquot platelets, usually to the OR at the end of the bypass, and they want 50 mils, those platelets, when we aliquot them from the mother bath, they're only good for 4 hours. And that is because the platelet storage bag is breathable. There is oxygen exchange through the plastic. And when we aliquot a unit of platelet into a smaller bag, that plastic is not breathable. And so platelets don't live very long there. So they outdate in 4 hours. So I talked about the compatibility for red cells and plasma. So red cell and plasma are exactly opposite in compatibility when we think of the donor and the patient. So what about platelets? Do we care about ABO in platelets? So yes, we do, because ABO antigens are expressed. Actually, I shouldn't say ABO because there's no O antigens, just A and B antigen are expressed on the platelet surface. And so when we give platelets, we prefer ABO identical, but it's not always available. So the platelets can be plasma incompatible or ABO mismatch. So plasma incompatible, meaning you give group O platelet to somebody who's not group O, so there is anti-A and anti-B in the plasma. The plasma is incompatible. Or ABO mismatch. ABO mismatch is, example is you're giving somebody who's group O an A platelet. So that's ABO mismatch. There is no incompatible plasma, but the platelet antigen is incompatible. So either way is not ideal, but sometimes we just cannot avoid giving out of group platelets. So our policy at Sick Kids is that infants under 6 months old, we give them ABO identical whenever possible, because they have a small plasma volume. There is less plasma to dilute out the incompatible antibodies. Patients over 6 months old, we can switch blood groups. It's not a problem giving group A to group B or group B to group A for platelets. But We generally do not give group O to non-group O patient unless they have a low titer of anti-A, anti-B. So group O people are the ones who make a higher level of anti and anti-B compared to group A and group B. So that's why we can give A to B and B to A, or B to A. And so something we're famous for at SickKids, because we started this many years ago, is doing ABO incompatible heart transplants. So some years ago, one of our cardiologists realized that patients who are on the heart transplant list, and these infants or small children, are not getting waiting a long time for a compatible heart. And so she started trying giving incompatible heart transplant. And so it works. So now we commonly do ABO incompatible heart transplant when we do not have a compatible heart donor and the transplant is urgent. So what do I mean by incompatible? So if the patient's blood group is O and you're giving them a group A donor, that's majorly incompatible. And you would never give group A red cells to somebody who's group O because the patient's anti-A would destroy and cause severe hemolysis of the red cells of the blood group A. And in the heart's muscle themselves do not express A and B antigens, but the endothelial lining of all organs express A and B antigens. And so if we give a group A heart, someone who's group O, the patient's group O, so they have anti-A, will attack the donor heart and reject the donor heart. So it does not work in adults. It works in kids, so infants, because they have low level of anti-A and anti-B, even when they're group O. So babies have no anti-A and anti-B at birth. They start making anti-A and anti-B at about 4 to 6 months of age, and that's only occurs after the gut is colonized because the bacteria in the gut is similar to A and B antigens. So that's when they start making 4 to 6 months of age. So up about 2 years of age, they still have low levels of anti-A and anti-B. And that's why an ABO incompatible heart transplant works in small children because of their low levels of anti-A and anti-B. But in the blood bank, we have to be very careful as to what blood products we give to these patients. So normally, if a patient's group O, we would give them group O red cells and group O FP and group O platelets. But if we have an incompatible heart, we put a message into the blood bank computer system to make sure we give them O red cells, but we give them A FP and A platelets if possible. And that is because these products contain anti-A, and these anti-A is going to interact with the donor A blood group and cause an acute rejection. So the first 7 days after the heart transplant is the most critical period. If we can keep the heart in there, the heart is likely to survive. So some special consideration for giving red cells and platelets is to prevent transfusion-associated graft versus host disease. Now, this GVHD is due to the donor lymphocytes engrafting in the recipient, and it causes a destruction of the patient's bone marrow. And there is no good way to treat TA-GVHD once it occurs. So we have to prevent this from happening by doing something to the blood products. So we irradiate the cellular product, which are the red cells and the platelets. They have white cells. Plasma, because it's stored frozen, the white cells are no longer viable, so we don't have to irradiate plasma. So who do we irradiate for? all infants under 6 months get irradiated blood at sick kids. Now, not all infants are prone to TAGVHD. The preemies, because the immune system is not well developed, are those who are getting a massive transfusion or an exchange transfusion are because they're getting a lot of blood. But at sick kids, because we have very sick children and many have a cardiac condition, and the cardiac condition can be associated with DiGeorge or deletion 22q, especially truncus arteriosus or interrupted aortic arch. It could be associated with DiGeorge or deletion 22q. So we have 6 months, and we have a test for 22q deletion. If they are found to be positive for the 22q deletion, we put a message in the blood bank computer system, and they will get irradiated blood for life. Otherwise, at 6 months old, if they don't have this syndrome, we stop irradiating for these children. All hem-onc patients and bone marrow transplant patients, because they're immunosuppressed. HLA matched platelets are because of the similarity of the HLA type with donor and patient. Generally, these are given to the hem-onc patients, so they would be irradiated anyway. Directed donations. In Canada, directed donations are only allowed from parent to child, and because the HLA types are similar, even if the child is not immunosuppressed, they can have TAGVHD. That's why all directed donations have to be irradiated. We don't do many directed donations at sick kids anymore, only rarely when the parents really want it. So now we move on to plasma. Maybe I'll stop here for a minute. Any questions about red cells and platelets?
I was just wondering, when you test the blood and they do have viruses, do the patients get notified, or the blood donor?
The donors, yes. The donors, the blood center sends them a letter telling them what it is, or what they think it is, and advise them to go to the family doctor to go get retested. The tests that the blood center uses for blood donors are very sensitive, so they're false positive. So sometimes donors get very panicky when they get a letter, but that doesn't always mean they are truly positive, because the tests are so sensitive. So the letter advises them to go get retested.
Thank you.
Oh, you're welcome. Any other question? Well, we have time for questions at the end if you have any more. Okay, plasma. So frozen plasma made by the Buffy-Coat method is called FP. So even blood bankers talk about FFP, but FFP was made from the old way, the old method of production, in that the plasma is frozen within 8 hours, and so it's called FFP. When we make plasma with the Buffy-Coat platelet method, because platelets can be made up to 24 hours, so the plasma is frozen up to 24 hours, and so it's FP. They really contain all the coag factors, and so we just say FP. If there is another way to collect plasma, is similar to single donor apheresis platelets. It's called apheresis FFP, and that's FFP because they're only collecting FFP. They're not collecting red cells, and then there's no production, so it can go into the freezer within 8 hours. These are big bags, roughly about 500 mils, so it's rarely used for patients. So you will not see FFP when you transfuse. You will see FP. The FFP are mainly used for fractionation, making fractionation products. So the dose of plasma is 10 to 15 mils per kilo, and it will increase the factor levels 15% to 25%, and that's increased adequate for hemostasis. It's 30 minutes required for thawing. So you need to give blood bank some time when you ask for FP. So I understand you have a later lecture on hemostasis, so I'm not going to talk too much about this, but FP and FP is given for bleeding, for coag factors. So what do you think is the right answer? INR PTT predicts bleeding, so all abnormal values must be corrected. You give plasma only if the INR or PTT is more than 1.5 times in a bleeding patient or one about to undergo invasive procedure. And plasma is the best option to reverse Coumadin in an emergency situation. Number two, good. So a little bit about the test. INR is the test for PT, the prothrombin time, and the INR is comparing the ratio between the patient and the normal. And it was developed to monitor oral anticoagulant like Coumadin. PTT assesses deficiencies of the intrinsic pathway, and it was developed to diagnose congenital factor deficiencies. And what is the most important predictor of bleeding risk? Is it the INR, the PTT, or the bleeding history?
Bleeding history.
That's right. So the bleeding history is the most important predictor of bleeding risk rather than the test, because these tests were not developed to predict bleeding. And this study shows that a mildly elevated INR or PTT do not predict bleeding. Moreover, if you try to correct a slightly elevated INR, it will not correct because the INR of FFP is not 1. So if you're adding 1.3 to 1.3, it will not correct. Plus, if we look at the curve, it's not a straight line. So the zone of normal hemostasis is 30%. The zone of anticoagulation is down there. So if we want to move a patient's INR from 3 to 1.7, we only need 15 mils per kilo. But to move them from 1.7 to 100% for 2, which is 1, you would need 4 liters of fresh plasma. I'm talking, this is an adult dose. Okay, so there is no need to correct INR to normal. Okay, so between 1.3 and 1.7, there is no need to give FP to correct. We still use 1.5 in sick kids, but most of the adult hospitals have now moved to 1.7 or 1.8 before they will give plasma. Okay, and so also, now that there is a factor concentrate available, it's called prothrombin complex. It contains factors 2, 7, 9, and 10, and those are the vitamin K that dependent factors that Coumadin targets. And so, if we need to reverse Coumadin in an emergency situation, such as before an invasive procedure with active bleeding, now the proper use is prothrombin complex rather than plasma. So platelets are suspended in plasma. The labile factors, which are 5 and 8, are preserved in the frozen state and the present in frozen plasma. But the stable factors, 2, 7, 9, and 10, are preserved in the liquid plasma. So that's in the FP as well as in the plasma of the platelet concentrates. So if you're giving platelets, you've actually given plasma that contains 2, 7, 9, and 10. And ICU patients, when they need plasma, they need 2, 7, 9, and 10, and not 5 and 8, because only hemophiliacs need 5 and 8, and we have factor concentrates. hemophiliacs. And so once in a while we get a call from CCU and said the patient is volume restricted and they need plasma and platelets. Can you make the platelets more concentrated? And I'd say platelets do not concentrate well, plus platelets are in plasma. So if you've given 300 mils of platelets, you've given 300 mils of plasma as well. So you don't need to give another 300 mils of plasma. Cryoprecipitate is made by thawing a unit of fresh frozen plasma at 1 to 6 degrees. It contains factor 8, fibrinogen, and factor 13. So this was developed many years ago for the factor 8 to be given to hemophiliacs. But of course, we don't use this anymore. We have factor concentrates for hemophiliacs. And so the main use is for fibrinogen. So in non-bleeding patients, we only need to give fibrinogen when the level falls below 1. And it often happens in the smaller children after their OR because they've been diluted so much after the cardiac OR that be with red cells and plasma and platelets. And so their fibrinogen is below 1. So we would give them a unit of cryoprecipitate to bring up the fibrinogen. But more and more, we are now using fibrinogen concentrate. We now have fibrinogen concentrate available that it only contains fibrinogen. So, and the pediatric dose is 50 milligrams per kilo. Now in cardiac surgery in the OR, they're now all using FC instead of cryoprecipitate. The dose is 50 milligrams per kilogram, and they may repeat once if they need it. Now, this is used in many countries, like in European countries for many years. So we know it works and we know it's safe. The benefit is that FC has a longer shelf life and there is no refrigeration required. And so for hospitals who do not have a freezer space, they do not they do not want to stock cryo. They are using FC instead. The disadvantage is that it needs reconstitution. So when blood bank issues a vial cryoprecipitate, the anesthesiologist or the bedside nurse would need to reconstitute, and they would need to calculate how much they give. In adult patients, it's easy, just give the whole vial. In children, you have to calculate how much of the vial to give because it's 1,000 milligrams per vial. And the other disadvantage is that it's expensive compared to cryoprecipitate. So there are pros and cons of using one to the other or the other. At SickKids, we haven't consciously decided to give exclusively FC. So, and it still depends on the clinician's preference. In ECMO, when they are ECMO, the transfusion triggers are slightly different than when they're not. So they need a higher hematocrit, higher platelet count, a higher fibrinogen, and they also need enough antithrombin, so to keep them anticoagulated. There may be some slight variability depending on the underlying conditions, the length of ECMO, the bleeding risk, etc. But generally, these are the numbers that we follow. We've been in discussion with the ECMO team about switching from cryoprecipitate to fibrinogen concentrate, but we have not made a decision yet. So I mentioned that plasma we use in the hospital, it's male plasma. Where do the plasma from the blood donors, of female blood donors go? They go to make fractionation products, or in our system, we call them derivatives. So CBS contracts with 2 fractionators to process plasma collected from Canadian donors, and they're made into albumin, IVIG, and factor VIII. Now, this factor VIII that we make from Canadian plasma, we actually do not use in Canada because all our factor VIII concentrates are recombinant. The other products are bought as finished commercial products on the open market. So manufactured products are made from thousands of donations pulled together and put through the fractionation process. So most of the factors are recombinant. There are only a few that are not that commonly used, that they're still human derived. And prothrombin complex for warfarin reversal is plasma derived. So is antithrombin 3 and fibrinogen concentrate. Those are from human plasma. And so these are some pictures. In Canada and in sick kids, that we have 3 types of IVIG. We have cytogam. Cytogam we mainly use for CMV treatment or CMV prophylaxis in organ transplants. For example, if we're giving a CMV positive heart to someone who's CMV negative, we would try and prevent them from getting CMV by giving them cytogam. Winrow we rarely use. This is developed for prenatal patients, so we rarely use in sick kids. So the general rule for derivatives is that you order to the nearest vial. We always issue to the nearest vial. Factor concentrates are never exactly what you think they should be. When you order 1,000 units, you might get 990 or 1,100. So we just give whatever it's the closest. Because all these factors are expensive. So people always like to ask me how expensive they are. How expensive do you think they are? So this is the Canadian Blood Services budget. It hasn't really changed all that much from this. So the Canadian Blood Services, they supply 9 provinces in Canada, and the budget is 900 and something million, so almost $1 billion. Half of that money goes to make transfusible products, which are the red cells, the plasma, the platelets, and the half goes to make plasma protein products or derivatives. And out of those plasma derivatives, about half are factor concentrates and about half are IVIG. And each province puts into the CBS operating budget a proportion of the blood products they use. And so Ontario has about 50% of Canada's population. So Ontario put in 50% into the CBS operating budget. And so, meaning all the blood products that we transfuse come from our money, taxpayers' money. Hospitals do not pay for any of these products. It all comes from the Ontario government. Okay, so how much does red cell cost? So roughly, anybody wants to guess, or just go on? Okay, I better go on. So this about $400, and these are just CBS costs to collect the red cells, and the hospital cost to transfuse is not included, as well as the fractionation products. I said they're expensive. So how expensive? So we usually think of 1 unit as $1. So 1,000 units of factor VIII would roughly cost $1,000, but it actually can vary quite a bit from a low number to over $2. And recombinant factor 13, it's $11 per unit. It's very expensive. Recombinant 7A, we also say 1 microgram costs $1, but actually it's gone up. So the cost is over $1,200. Fibrinogen costs $445 per vial. Immune globulins, 1 gram costs $51, but cytogam, 1 vial of cytogam, 2.5 gram costs $1,333. That's the latest numbers. Albumin is relatively cheap because in the scheme of fractionation, after the coag factors and immune globulins are removed from that pool of plasma, what's left at the end is albumin. So it's sort of like a end product or byproduct. So that's why it's relatively cheap. But it's not cheap because overall, because we do use a lot of albumin in Canada. Okay, so I've finished almost on time, but I have a few minutes. Cecilia says I can take 5 minutes for questions. So any questions?
I have a quick question.
Yeah.
Does cryoprecipitate, does that have to match ABO? Is there any matching with that one?
We generally do not match because it's hard to match and it's only a small volume. So cryo only has 10 mils. So we generally do not match. In the AB, we don't match. We can give any blood group to patients. In the ABO incompatible heart, we do try and match, but it's often not possible. So we would go down, and from my table, you can see there's a list of our choices. I can go back to the table. Oh, here. So let's say we try. So this is that's why we list them here. So we try and give group A. Group A cryo is not hard to find. AB is almost impossible to find. So we give group O as the last choice. But in other patients who are not getting an ABO incompatible heart transplant, we just give them whatever blood group we have.
Okay, thank you.
You're welcome.
Okay, any other questions for Wendy?
Hi, I just have a quick question.
Okay. Go ahead.
Is a freeze-dried plasma, does it have the same efficacy as frozen plasma?
We don't have freeze-dried plasma in Canada yet, so and all I can see are studies that are ongoing. So I don't have actual knowledge of the efficacy of freeze-dried plasma. I'm sorry.
Okay, thanks.
Okay, thank you so much, Wendy, for sharing your definite expertise in this area, which is very complex to say the least. Thank you so much.
Well, thank you for having me.
Mm-hmm.